The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety.
In this episode of the Fast Archives miniseries, we have a talk that dives into a rare but critical event in obstetrical care, the amniotic fluid embolism, or AFE. Our speaker, Allison Herman, brings a wealth of experience to the topic. Having spent a decade flying for a hospital-based program in California, she recently returned to the ER and now serves as the pediatric emergency care coordinator. During delivery, when hit with what she calls the 3 Bs, quick thinking and experience in dealing with these life-threatening conditions is of the utmost importance. If you're interested in learning about high-risk OB cases and how emergency medical services handle unexpected complications, this talk is a must-listen. She offers valuable insights into critical thinking, teamwork, and the importance of solid training when stakes are high. And if you want to hear more talks like this, check out our other episodes in the Fast Archives miniseries. Now on to the episode.
My talk is called Bamboozled by the 3 Bs. And one, bamboozled because I was bamboozled into speaking by Bauer. I basically got a text that said, "Hey, I'm putting you down for a high-risk OB topic. I know you like it. Okay, see you in 2 months. Cool, bye." But I think in the EMS industry, when we talk about OB, everybody runs the other way. Nobody wants to talk about it. They want to call the specialty team and they don't want to deal with it. But why is that? Because I think it's easy to push it off on other people because it truly is a specialty. But when everything's going wrong and we're called to show up to these patients, it's you and I that are now that specialty team. So today we're going to be going through a case study that our hospital encountered and our flight team encountered and transferred out. But before we do that, I want to play a quick audio and give a time to honor some survivors of AFEs. And we're going to hear a quick audio clip from a mom who actually encountered an AFE and hear her experience. So here we go.
Amniotic fluid embolism. 3 words I had never heard until July 22nd, 2019, 5 days after my only son was born. They were quickly followed by cardiac arrest, ECMO, massive transfusion, hysterectomy, words I couldn't quite comprehend in the context of giving birth. I was supposed to go to the hospital, have my baby, and come home. Amniotic fluid embolism changed everything that day. It changed my life, it changed my story, it changed my family. If we're lucky enough to survive an AFE, we watch as this continues to happen to other families, as mothers and babies are thrust into the limbo between life and death, desperately hoping they somehow make it out of what should have been a routine birth. I will never be grateful for those 3 words and the destruction they've caused, not only for me and my family, but for the thousands of lives they've touched and claimed. And yet, I can see the light that's been brought into my life in its wake, the people and the stories I've had the honor to hold, the families I've cried with and connected to as they learned those 3 words for the first time. To the moms and the babies that we've lost, I am so sorry. You deserve to be here. You deserved to live, and we will continue to fight to honor your stories and your lives. We will not sit back helplessly. We will find a way to end AFE.
Why do I care about this topic so much? I had a high-risk pregnancy, and everything went well. So this is my 15-year-old and my 13-year-old twins. And I remember even going through that whole experience, everything was going well. I was being monitored. I didn't have a bad outcome. But even as normal as things went, it was still a terrifying experience. So when we're called to these cases, these studies, we're called in as a team to take care of real people, of families, often on their absolute worst day, in their worst experience and the worst thing imaginable. So we're going to go over this case study today. That is an example of simply that. We're going to talk about our team. I'm so proud of them as we were going through these case studies and going through this chart. And I think the outcome is reliant on the fact that our team drills this exact scenario. So they were prepared. when this happened. So let's dive in here. What do we know about amniotic fluid embolisms? We really don't know a ton about them. The literature has been pretty spread of what we think it is versus what we know it is. But we do know is that they are often sudden, they're catastrophic, and they're completely unpredictable. We know that they happen in 2 to 6 per 100,000 cases. And what it is it's a clinical diagnosis only. This is a clinical presentation. A lot of these moms end up in autopsy. They open them up and there's no findings. What we do know is that there's fetal debris that's found within maternal circulation. But initially what we thought is that it causes this physical blockade. And that's not the case. They're not opening these moms and finding like this big saddle PE or this big emboli nature of fetal debris within that vasculature. And there's actually been studies that they've pulled blood samples from moms with PA lines and CVICUs that are completely stable otherwise. They have fetal debris in those blood samples, but they don't have any signs of AFE. So this isn't a finding or like an official diagnosis. It's more of an anaphylactoid type reaction and response that happens. We know that it occurs during labor, interpartum, or within that immediate 30-minute postpartum period. So we're going to go over 3 Bs today. And when we talk about being bamboozled, it's going to be being bamboozled by these 3 Bs. And these are characterized as breathing, blood pressure, and bleeding. All sudden and acute changes. But it's also important to note that these moms should be afebrile within this presentation, and the onset does have to be within that 30 minutes of delivery. And afebrile mainly to exclude any cause from sepsis. We have our baby here surrounded by amniotic fluid. And what we know is that amniotic fluid enters maternal circulation through that venous system. It goes to the lungs and they get pretty sad. What starts happening is we're getting this overwhelming release of bradykinin, prostaglandins, histamines, and we get this full-blown IgE-mediated response. It causes PO vasospasm, we get pulmonary hypertension, pulmonary edema, respiratory distress leading to failure, and profound hypoxia. From there, we start entering our cardiovascular collapse, and our heart gets pretty sad. We see a decrease in our coronary blood flow, our SVR, our cardiac output. We start getting some pulmonary congestion, myocardial capillary damage, leading to hypotension, shock, and a decrease in our fetal circulation. So what we're going to see on our monitoring, our fetal monitoring strip, are prolonged decels. And when we're getting prolonged decels, we should hopefully be moving towards getting that baby out, performing that resuscitative cesarean section. So amniotic fluid continues to go through that maternal circulation via the intrapulmonary shunts. And what happens is we get this full-blown thromboplastin release, causing a consumptive coagulopathy. And a lot of times in these moms postpartum, they get a cardiovascular collapse related to DIC and massive hemorrhage, right? But what's different about DIC and AFE presentations is that we get the DIC that occurs after cardiovascular collapse has already occurred. So now that we have a little bit of a background in pathophysiology for our AFE, let's jump into our case study. So November 2022, just last year, we had a patient present at our facility. Mind you, we are a pretty small level 2 trauma center. We are about 1.5 hours by ground, 35 minutes pad to pad by air. We're relatively rural. This patient was a 26-year-old female, G2P1, 19 weeks and 1 day gestation, history of type 2 diabetes, maternal obesity. And when they say maternal obesity, that was a big stretch. Her weight was not terrible. I would not call her that. Depression, asthma, hyperlipidemia, migraines, and pseudotumor cerebri. She had 1 prior cesarean section, presented with a lack of fetal heart tones in clinic, just on a routine OB appointment. So later, they did send her for a formal ultrasound, which confirmed a fetal demise at 15 weeks and 4 days. And she was a known Jehovah's Witness. So due to these religious constraints in accepting blood products, her OBGYN went over the decision for what would happen during procedure, and also do you go towards induction versus a D&E. And what they elected to do was an outpatient D&E for her, because they felt like they could do better bleeding control in the OR if this was to happen. They talked over, if we do need to give you product for resuscitation, what would we give you? And they decided cryoprecipitate and albumin, those were okay and acceptable. They drew a CBC and some coags, all completely normal prior to the case. So at 1904, patient went in for induction of anesthesia. At 1907, she was given some propofol and fentanyl. At 1935, the anesthesiologist noted a marked increase in her heart rate and her respiratory rate and thought maybe it was a pain response. So redosed her with some fentanyl. At 1936, her heart rate continued to climb. She was up into the 190s and her end tidal was falling rapidly into the teens. And that's where our anesthesiologist paused and said, I think that this is an amniotic fluid embolism. I think creating this pause in this moment immediately put the team into the positions they needed to be to care for this patient. And I think this was one of the most pivotal moments and statements that he could have made throughout the entire case. So what ensued was 20 minutes of CPR. She was in full PEA arrest. So they followed their ACL's protocols. And at this time, they started calling everyone in. They called our flight crew to the bedside to be part of real-time resuscitation. They called in another anesthesiologist. They called in the ECMO team, and our whole cardiovascular team to ECMO, cannulate patient on ECMO. They called in a second OBGYN, since the first one was still finishing the procedure. And he called in all of the resources to be on standby for this mom. At 2019, they started placing all of the lines. They placed a right IJ and they placed an ART line for real-time resuscitation, which we're learning is super important. At 2042, they did a bedside TEE, which showed right ventricular failure and poor LV filling. So essentially during her resuscitation, as they are going along down their algorithm, they gave her 4 rounds of epi. They eventually did get that heart rate back prior to cannulating her on ECMO. As they're continuing to stabilize her, they did put her on an epi drip. They added some milrinone. They gave her some more albumin. They gave her some calcium. I saw William this afternoon. I was like, oh, shoot, William. They were throwing the kitchen sink at her. And they did dictate. They thought they were giving calcium for that, cardiac output. They gave her some dexamethasone, maybe to cover that IgE response. Pulmonary edema that was going on and all that respiratory stuff that now she was fighting. And then they gave her all of our best friends in resuscitation, right? Our rocuronium, our Versed. And as they're continuing down the line and having the discussion with family to cannulate patient on ECMO, they gave her a bolus of heparin. So they cannulated her for VA ECMO at 2103. And shortly after cannulating her on ECMO, they noted that she was starting to ooze. And she was starting to bleed from her perineum. They repeated some labs and her fibrinogen was markedly down to 108 now. And her hemoglobin was down to 5.4 from initial 11.3. So full-blown consumptive coagulopathy. To treat this immediately, what do our uteruses like to do post-procedure, postpartum? Wave, flap, and bleed, right? So they gave her some Methergin to treat uterine atony. They gave her a pack of cryo, and they gave her not 1 gram, but 2 grams of TXA. And their hands were pretty tied, right? So from there, they looked at our flight crew, patients cannulated on ECMO, and they said, GTFO, off to tertiary center with you, right? So ICU course of her care, she underwent decannulation in the OR 2 days after admission. She had poor pulmonary reserve in the setting of severe anemia. Her hemoglobin got down into the 2s to 3s. Because of this, they felt like they really didn't have a whole lot to play with. So they did end up giving her 2 units of Hemopure as a last-ditch effort, which they had authorized for compassionate use only. They decided to do conservative blood draws with pediatric tubes, and the team met to decide how frequently these labs should be drawn and what they were comfortable with. Felt like they needed to medically manage her. And she required aggressive ARDS ventilation strategies. Her white count ended up at 57.8. She had bilateral lung consolidations requiring broad spectrum antibiotics, free fluid around her endometrium. She had some liver necrosis with a gnarly transaminitis due to a liver infarction post-arrest, which eventually had started to resolve. Some mild ascites. Of course, she's full of fluid. It's the only thing we can give her to resuscitate her. However, she was extubated and fully neurologically intact 13 days post-arrest. And a lot of these moms are not so lucky. These moms have about a 60 to 70% neurological impairment in these cases. So a pretty cool win for our team. However, she did have bilateral PEs, a right ventricular thrombus, an IVC thrombi. She was basically in a full thrombotic storm. Because of this, they worked her up for an antiphospholipid syndrome, which was negative. And she did end up hit SRA positive and placed on Angiomax. In deciding kind of long-term management for her, they did prefer to put her on a direct oral anticoagulant. They preferred Eliquis for her. However, she did choose warfarin because of its reversibility and discussions with family. She was eventually repatriated back to our facility about 20-something days post full arrest for further inpatient care and ultimate inpatient rehab. And I think in the EMS world, we don't really talk about these OB emergencies enough. So I think we need to talk about it more. And I think what was so pivotal and so huge for this case is that our team trains on this. We are a small facility. And I think it would have been a lot messier with a really poor outcome if our team wasn't prepared. And I think because of that, that patient's alive and made it out of our facility at least. So let's go back to the 3Bs and how we're going to treat them when we get fully bamboozled. First off, we're going to see sudden changes in breathing. So our goals are always to maintain our SATs greater than 95. And on these moms, we want to blast them with high flow O2. There's no amount of O2 that's going to be too much for these moms. We want to provide early intubation. If they're later term, full term, we want to make sure that we're also addressing difficult airway management styles. These moms are big, they're full of fluid, and they are friable. So making sure that we're anticipating difficult airways as well as providing early intubations for these moms. They're also going to require aggressive, potentially ARDS type strategies for ventilations. They've got pulmonary edema, profound hypoxia, and they're going to need optimum oxygenation. Has anybody in here ever made fun of an OB nurse for wanting an 18 gauge and not a 20? So there's a really good reason that these OB nurses want large bore IVs and they're going to scoff at your 20. They know that these moms, when they need resuscitation, they need it now and they need a good line placed. So make sure that you're getting that 18 gauge in. We want to make sure that we activate our MTP early. These moms end up on massive amounts of blood products requiring that. So we need to know our MTP protocols, know how long it takes you to get your packs of product. We want to position that mom to the left lateral if we can't. Make sure that we're providing that manual displacement of that uterus. Vasopressors, inotropes, a real-time TEE to see what's actually really going on with that heart and that cardiovascular function. Probably the only sexy term people think of in the OB emergency world, performing a resuscitative cesarean section, previously known as a perimortem C-section. And I think they're moving towards the words resuscitative cesarean section because calling it perimortem means the mom's already arrested and is probably already dead, right? But providing that resuscitative cesarean section, delivering that baby is not only for the baby, but it's also for the mom. It's going to improve all of her perfusion and that tone. Improved cardiac output and uterine perfusion helps restore that tone as well, which is going to help your blood pressure. Place your art lines, place your central lines. We're going to stop the bleeding, packing, tocolytics, like whatever is going to clamp that uterus down. Uterine artery ablation. We want to do everything that we can to control that bleeding and address our coagulopathy aggressively. AFEs are sudden. They're unpredictable. They're completely catastrophic. They're often the worst thing that families can imagine in the moment. I can't encourage you guys enough to be prepared, to simulate these, to lean on your teams, to practice, know your patients, listen to them, monitor them closely, and know how to respond when you guys get bamboozled.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.